Hello, everyone. My name is Javier Pinilla. I'm a hematology oncologist at the Mazyar Shadman Cancer Center in Tampa, Florida, where I'm the head of the lymphoma program. And I have the pleasure to join today with me, Dr. Shadman from the Fred Hutchinson. Please go ahead and introduce yourself.
Hi, Dr. Pinilla. My name is Mazyar Shadman. I'm a lymphoma and CLL physician at Fred Hutch Cancer Center in University of Washington in Seattle. It's great to be here today.
Wonderful. Well, thank you. Thank you to share with us, a very interesting presentation that you have done this year at the ASH meeting. And the title of the presentation is Enitociclib, BIP 152, or formerly BAY 1251152, selective and active CDK9 inhibitor. I guess you're presenting the preliminary safety and early signs of efficacy in patients with non-Hodgkin lymphoma as well in chronic lymphocytic leukemia. So, tell us a little more about this trial. And I guess I understand there's very preliminary data that you are already showing here, but you can really give us some kind of overview. That will be great. So please go ahead.
Sure, we'll be happy to. So, as you mentioned, we presented data on VIP 152 or Enitociclib, which is a drug that belongs to the family of drugs called CDK9 inhibitors. And as you know, there are a number of molecules in development, and we presented some preliminary data on B-cell non-Hodgkin lymphomas and just very, very preliminary data on CLL cohort. Just as a quick introduction, Enitociclib inhibits CDK9 and impacts on some of the important oncogenic proteins, namely MYC and MCL1. And there's a lot of scientific rationale and interest in using these molecules in treating different types of malignancies, and namely B-cell malignancies and CLL. So the drug has been tested or being tested in 2 clinical trials, one mainly focused on relapsed refractory non-Hodgkin lymphoma, and that's a study that has finished enrollment in the monotherapy, basically cohort, and 16 patients with different type of non-Hodgkin lymphomas were treated, including large cell lymphoma with double hit, cytogenetic changes, and also transformed follicular lymphoma and Richter's. And for this presentation, we also included 4 patients with a CLL diagnosis. As I mentioned, this is monotherapy and a phase 1 dose escalation. So the patients we presented received the first dose level, which was starting at the 10 milligram and then followed by 15 milligram. As a quick reminder, this is an IV weekly infusion drug. And basically the patients who were treated, looking at the whole cohort, both NHL and CLL, we had really high-risk patients, 20 patients. And for the ASH cutoff, we presented the pooled safety analysis, which mainly grade 1 and 2 GI adverse events were the main side effects we observed. Neutropenia is an on-target adverse event, and we saw that neutropenia occurred in 8 patients out of 20. It was well managed by supportive care using growth factors. And at the time of presentation, we did not have any discontinuation due to adverse events. There were 3 deaths, unfortunately, but all due to disease progression in this study. I wanted to mention, just put this in comparison with some of the other molecules from this class and focusing on the side effect profile. We did not see any increased rate of high-grade liver toxicity. For example, the one case of the only grade 1 elevation of the transaminases is what we observed in this study, which I think it's important to put it in context. In terms of efficacy, in the NHL cohort, there has been activity for example, 2 patients with double hit large cell lymphoma who had CR at cycle 8, and they initially started with kind of stable disease, and the quality of response improved over time. And recently, a transformed follicular lymphoma patient also had officially stable disease, but with tumor reduction at the range of 16%. So this is a type of drug that you need to give it time to work, and we've seen that in non-Hodgkin lymphomas. As I said, for the CLL cohort was very preliminary and, using the first dose level. And what we did not observe any efficacy, but there was no safety signal either. And, when we looked at the pharmacodynamic of the drug and the inhibition of MYC and also MCL1, at the dose level, at the first dose level, we did not see that there was any downregulation of MYC or MCL1, which was expected given the low dose level. So, the study needs to have a longer follow-up, and we need to look at the data in future meetings. So basically, in conclusion, an important class of drugs in general with a lot of scientific rationale to investigate, and early days for this molecule, and we need to look at the long-term follow-up and deciding on the strategies to best deliver this drug either as monotherapy or in combination with other agents, and that's something that will be decided in future. So I'm happy to answer any questions about the study.
So I think, as you just pointed out, I think it's exciting to see at least new molecules. Obviously, I think we are targeting the apoptotic pathway for NHL and CLL that is being very well, show with venetoclax, at least in CLL. And obviously, we always need to really order alternatives for patients when they become refractory. So what do you think in the future? We may see, I'm sure, maybe in the future, more data. As you just pointed out, they are quite preliminary data. You think that there maybe is a possibility to combine this drug in the future with other agents that may really potentiate the efficacy? It's something that it may happen. You may not know, but what do you think about that? It's maybe a possibility.
Yeah, no, actually, first of all, as I said, we need to kind of learn more about the safety profile, but this seems to be a reasonable partner to some of the other agents for CLL. And actually, there are already plans that, and the studies are kind of, the study will include combination cohorts with BTK inhibitors and even venetoclax and prednisone, and kind of having this class or this molecule as a partner to some of the other effective drugs, and with the overall goal of improving the quality of responses while keeping the combination safe. So absolutely, that is the plan from the standpoint of the sponsor.
That's great, and I think it's always a good news for our patients with NHL and CLL to see the new developments in new molecules that maybe one day can come up as single agent or maybe in combination. So thank you so much for sharing this information with our patient, and I'm looking forward to see more data in the future meetings. Thank you. Thank you so much, Dr. Shadman. Thank you.
Thanks for having me. Thank you.